So welcome to the new episode of the JCMC interviews series. I am Michele Introna, neuroanesthesiologist at Istituto Best of Milano. I'm social media editor of the Journal of Clinical Monitoring and Computing. And today, for the first time, I'm going to interview Dr. Ana Spataru, who is a neurointensivist at Southampton General Hospital, UK, who is the first author of a very nice systematic review we published in the JCMC, who is called Performance of Closed Loop Systems for Intravenous Drug Administration, a Systematic Review and Meta-Analysis of Randomized Controlled Trials. And we are also lucky to have with us Dr. Coeckelenbergh, who is an anesthesiologist at the Paul-Brousse Hospital in Paris, France. So both of you are welcome to this interview.
Thank you.
Thank you.
Okay, I would start with Ana, asking her to introduce her work and to give us some quick informations on how the work was, how the idea came out and how they implemented their work.
So I'm going to start by saying that I first became interested in closed loop systems for drug administration during my anesthesia residency. So I did a rotation in Belgium where one of my mentors was using good closed loop systems at that time and was giving propofol and opioids intraoperatively using automatic systems. So I think for me, the idea that you have an automatic system that can take some of the workload of the anesthesiologist and give drugs in a reliable and precise way was a very appealing idea. And this is the first time I became interested in it. And then in the last few years, I came across more and more papers describing and focusing on very complex closed-loop systems, able to give not only anesthetic drugs, but fluids, sevoflurane, not only with single loops, but multiple loops. So I thought I would take a closer look at the available literature, and this is essentially the way that the idea for this systematic review came about.
And if you could give us shortly what are the main endpoints of your work and the main results you think a reader could gain from your work.
Sure. So in this systematic review, I was specifically interested in comparing closed loop systems with medical practitioners for the administration of intravenous drug during anesthesia or in the intensive care unit. And our main outcome was looking at the performance of drug administration, and that was defined as the duration that a specific physiological variable was maintained within predefined targets. So, for example, that could be BIS for systems that administer propofol, or that could be the blood pressure for systems that administer vasopressors or vasodilators, or that could be blood glucose for systems administering insulin. Other than that, we also wanted to look at workload during anesthesia when these systems were in use. We also looked at the safety. We also looked at the duration of post-anesthetic recovery and at the drug doses. So the main conclusions were that the automatic systems reduced the duration of abnormal blood pressure during noradrenaline and vasodilator administrations. And another conclusion was that we got a reduced duration of post-anesthetic recovery when automatic systems were in use for the administration of neuromuscular blockers and propofol. because we had pretty conservative thresholds for heterogeneity, we couldn't give summary estimates for the performance of propofol administration and noradrenaline administration, but there was a very strong signal that these systems indeed outperform medical practitioners.
Thank you, Anna. I would like to ask Sean, because you all listeners could read his editorial with other co-authors, quite enthusiastic regarding the work by Anna, but in general, the concept of automation in anesthesiologists. Do you really think we are up to the moment when these kind of systems will start to be used also in clinical practice more widely than they were in the past years?
Well, we still have hurdles to their implementation, most notably regulatory hurdles. But if you think about it, all around us, there's automation. Just when you cool down the OR, you're using a closed loop system. When you're driving your car, there are closed loop systems. When you fly a plane, there are closed loops. Almost everywhere around us, we're able to maintain what we want within precise targets. Why aren't we doing it in anesthesia yet? Why has it not been implemented? I think the main limitation today is regulations. We're going to have to do trials and safety trials to show that it works. And there's been quite a bit of work recently on two types of closed loops, fluids and vasopressors, which have shown a lot of precision, like Anna shows in her study, but also safety. We're able to use these tools without having any negative effects. So are we going to implement it tomorrow? Tomorrow is maybe a little bit premature, but I sure hope that we'll implement it within the next decade, because we're going to be able to have, like Anna showed in her study, patients that are more often in target, and not just for propofol, but for neuromuscular blockades, for vasopressors and blood pressure. And there's a lot of debate on which blood pressure target to have, but clearly hypotension has been shown to be bad. So we'll be able to avoid that more often, optimize cardiac output, and all this while having our hands free and being able to focus on other things. So yes, I think it's going to be implemented, and I think we need to continue advancing on work like Anna's, which, it's a meta-analysis of randomized controlled trials. So it's really the highest level of evidence showing that these tools are extremely useful. So hopefully in the next decade, there's definitely work. And what we're doing now and what's getting on the market, for example, with fluids, is open loop systems. So for example, Edwards has put on the market the assisted fluid management system. I think it's available in Europe and it will be available soon in the US. And this system is actually derived from a closed loop and suggests fluid administration. And what it does is it interprets different components of pulse contour analysis, pulmonary vascular resistance, heart rate, and I'm sorry, I meant to say systemic vascular resistance, heart rate and blood pressure, and it gives suggestions to administer boluses of fluid. And so actually, if you consider open loop systems where the clinician can decide if he administers or not fluids to be automation, I'd have to correct myself. Automation is actually already here today for fluids.
Yeah, this is absolutely interesting, and there is a kind of dissociation I find between, as you said, the fact that we are more and more using automation systems and in our daily life, but still there is some resistance to introduce the concept that they can be used also in our workplace as physicians. And I have a question for both of you. Do you think there could be a role of automatic delivery systems also in the intensive care setting, or it's just a thing that will pass through the OR and will later on be used in the intensive care? And eventually what problems you see in a broad application of these systems also outside of the OR setting?
So I'm sure there is extensive applicability of closed loop systems for intensive care. In our systematic review, actually found just very little information about the implementation of such automatic technology in the ICU. But if you think about it, a large proportion of workload in the ICU, especially nurses' workload, is to adjust medication, being anesthetic medication, being pain medication, or vasopressors. So I think there is a big, scope for potentially using this system in the intensive care. Indeed, I think for now there is not a lot of information yet, but I'm sure they could be integrated successfully.
I have to agree with you. I think there's definitely potential with closed loop systems in the ICU, and clearly considering workload. So let's use the example of blood pressure management. So there have been studies that look at how often we maintain blood pressure in the ICU with vasopressors. And it comes out to more or less half of the time being in target, with a considerable percentage of the time being well under target. And why is this happening? I think it's really a question of workload. In our hospitals, nurses that work in the ICU have a very hard job. They have a lot of demands. It's really rare that they just have one or even two patients. They often have several patients. And if you have a repetitive task that requires continuous titration, they're not going to have the time to take care of just this because they have many other responsibilities. And this is why we find ourselves with almost always, or at least half of the time, being outside of target. And a study that we've submitted to the Journal of Clinical Monitoring and Computing, and that might be published after review, we looked at the maintenance of blood pressure in two types of intensive care unit populations. So in one of the studies, it's in major abdominal surgery, mostly liver transplant patients. And the other one is in brain injury patients. And what we find is that on average, the nurses will titrate the norepinephrine to maintain the target about 6 times in an hour, case in one study, while the closed loop system that we use modifies norepinephrine titration about 1,000 times. So we're at 3 orders of magnitude of difference in how often the norepinephrine drip is changed. And of course, the target is maintained much higher in a closed loop system. So I think there's potential. There's potential, like we said previously, to maintain higher targets. There's potential, like Ana says, to decrease workload. But there's really the question of targets. What targets are we going to use? Because for blood pressure and traumatic brain injury, we have to titrate it based on intracranial pressure and indicators of blood flow to the brain. But it's not always the same thing. In major abdominal surgery, you need to really think about fluids too, because there's a lot of the cardiac output is a major factor. And then if we're going to look at other kinds of closed loop systems, we have quite a bit of challenges. If we're going to target, for example, propofol titration, how are we going to do it? Because some patients have already an altered EEG state. So how are we going to use the EEG? Are we just going to use the process number? Like almost all the closed loop systems that have been published, to my knowledge, only use a process number. For example, target between 40 and 60. But more and more, we know that this doesn't represent every patient. It doesn't even represent every type of anesthesia. And in the intensive care unit, it's much more complex often than in the OR, because you have patients that have brain injury. You have patients that have encephalopathy. I mean, clearly we take them to the OR for a little bit, but often we have healthier patients neurologically than in the ICU. So there are a lot of challenges on which type of targets we're going to use and how we're going to use automated systems to maintain patients in these targets. But again, I think there's potential for decreasing workload and for improving care.
Yeah, thanks, Sean. This is really, really interesting. I'm personally much interested in the use of deliveries, like delivery systems in intensive care, and I'm also a strong believer on the potential applications, but I'm also aware of the limitations. As you said, like processed EEG is a quick number given to the clinician, but we know that it's not enough to give us the idea on the depth of anesthesia. So I'm going to ask to Ana, for your systematic review, as far as you know, it was used just the processed EEG, or there were other endpoints when titrating the closed loop systems?
So for closed loop systems administering propofol, the main physiological target was BIS. And most authors just used BIS and titrated it between 40 and 60. And I think that does make a lot of sense in anesthesia specifically, but I would agree in intensive care, it's certainly more difficult to find the target and to use an appropriate target. But what's been used in literature is indeed BIS, and that's just one number, and intuitively is simple to use, and it's appropriate to use in anesthesia. But then I think for intensive care, that would be an open question. And I'm sure that for some patients would be appropriate, but probably not for all of them.
And regarding also limitations and risks of this kind of technologies, for Sean, what do you think are the main risks and eventually limitations?
Okay, I'd rather start with the limitations, if you don't mind. So the main limitations are that these are just extra tools. They're not going to really determine the targets ahead of time. We need to be there to decide how it's going to administer, to set the targets ahead of it administering. And we need to also react to our environment. Closed loop systems are, the analogy I like is just extra hands and eyes. You know, they're constantly looking at a parameter, and they're modifying the infusions to maintain a target. But they don't anticipate events. They're not going to tell you if the surgeon's going to start operating. They're not going to tell you if the patient changes position or any other significant situation. If there's a massive bleeding that begins, there will be a delay for any reaction of these closed loop systems, while us as clinicians will see it right away. If we're talking to the surgeon, we'll be able to notice it immediately. So that's a big limitation, is the delay. Another limitation is the fact that, you know, your system is only as good as the sensor and as the effector. Again, a closed loop system is a system that has a controller that interprets what is being monitored and then determines how much of a medication to administer to get to the target. And it's constantly looking in a closed loop system at the error between its target and what it has, and tries to correct it over and over again. If the monitor isn't any good, for example, we're talking about the potential limitations of administering propofol using a processed EEG number. If for a given patient, the processed EEG number isn't reliable, then we're not going to be able to titrate our anesthesia correctly with the system. That's another limitation. It's the monitor. If the monitor is not good, you will have limitations. Same thing with the pump. If the pump's not able to react, or if the drug you give has a very long half-life, you won't be able to quickly change your targets. So those are some limitations. And then you have the risks. If, for example, your monitor is giving you the wrong information, the transducer cell for blood pressure, for example, if it's too low, if it falls to the ground, it's going to tell the closed loop system that you have too high of a blood pressure. And so it will stop infusing norepinephrine or whatever vasopressor you have. And so you end up possibly having the risk of having too much hypotension and its negative effects, and not noticing it because you're not aware of your situation of what's going on. So this again shows the importance of having a clinician that interprets and that also assesses the environment. This kind of problem can occur even if you don't have a closed loop system. Having your monitor telling you that the blood pressure is high when actually simply the transducer cell is too low, that's just normal clinical science. It's up to you to evaluate. So that's one risk, is that the closed loop misinterprets information because it's not in the best situation. Another risk that you can have as well, and this I actually saw, for example, with TCI in myself when I was learning. I learned intravenous anesthesia with TCI, not with bolus and continuous infusions. And when I was a second year resident, I could think in TCI, but I couldn't think yet in bolus and milligram hour infusions, because there was a model in my head. And if you have clinicians that are only trained with automated systems, you can end up having clinicians that aren't able to work without it. This, for example, has happened in aviation to a certain extent. You've had pilots that are flying, the autopilot turns off, and then they have a hard time adapting to their environment, and sometimes even to a catastrophic level. So that's another point. If we are to implement automation into our daily practice, we need to be sure that we can still work without it. So we'd have to train our young residents to work without it, and we would have to, from time to time, do so as well.
Yeah, regarding this point, I personally think that a possible game changer could be, as you said before, open loop systems, just for people to get used to the system and for people to understand that they are safe and they can be used and they will not take out our work and our professionality. So probably closed loops are still, let's say, the mean anesthesiologist still, I can't see it as a thing for now, because I know my colleagues. So the majority of my colleagues would probably accept more easily an open loop where they are advised to, instead of forced to, or the machine that do it by itself.
Yeah, I understand that point, but I think I need to say two things. The first is that closed loops cannot replace an anesthesiologist. It's impossible, because like I said, it's an extra set of hands and eyes. There's a controller that interprets a little bit, but it's not a brain. It's not able of what we call situation awareness, the capacity to understand your environment and predict events that occur and communicate with the surgeon, the nursing staff, etc. Closed loops are just doing repetitive tasks that are kind of workload intensive, and that we'd rather not do, and that we don't do as well as an automated system. The problem with open loop systems, which I think they're great, I think there are advantages to them, but one of the problems is that your workload doesn't decrease as much as if you use a completely closed loop system. So if you're worried about too much workload, for example, for nursing staff, an open loop system can perhaps even annoy the nursing staff, because they'll have to come back every time to confirm the change in the infusion. You see what I mean? Like I said, in one study, we have 3 orders of magnitude difference between the changes in infusions. If any of us would have to confirm 1,000 times in an hour the change in infusion, we wouldn't be happy, right? We'd have to be constantly clicking every, I don't know how many seconds, 10 seconds, confirm the change in infusion. How would we do that practically? It's not possible. So open loop systems are great. I think it's certainly a way to move forward in automation, but I'm convinced that we need to automate many of the components of anesthesia and intensive care so we can maintain patients better in target. And I think we will be able to personalize their care and improve their outcome.
Thank you, Sean. And last question, because our time is running out for Ana. What are your future perspectives on the topic? So are you working on something, or you have any ideas for the future?
So for now, I mean, I would agree with everything that's been said. I think there is no way that closed loop systems would replace anesthesiologists, but I think probably they would be able to reduce some of the workload and to improve the reliability of the process. I think I'd be very curious to see how that acts out in the future in other settings, specifically in the intensive care. I would also be interested to see more complex closed loop systems, specifically closed loop systems with multiple loops that are able to administer multiple drugs at the same time, so where possible, multiple drugs with fluids at the same time, maybe mirroring a bit more the actual real work of an anesthesiologist. And I think that's certainly an area where there will be developments in the future, and I think it's an area to watch, certainly.
Thank you, Ana. Thank you, Sean. It was really interesting to hear you. It's a terrific topic. I think it's really the future. I'm a strong believer that this is going to be implemented in our clinical practice in the next years. So thank you, both of you, for participating in our interview series. It was really a pleasure to meet you.
Thank you so much for the invitation. Hey, could I just ask one last question, if you don't mind?
Absolutely.
So Ana, you said that you went to Belgium and there was a mentor of yours
Who
had an automated system for propofol and remifentanil?
Yeah.
What hospital was that in?
Well, it was Erasmus, and it was Monsieur Barvet. I think it's only one, probably. I don't know if he's still doing it, but he was doing it big time when I was there, I think 10 years ago now.
Yeah. It's funny, he was my mentor as well. So
I think there are a lot of people who worked with him who actually published on closed loop systems. I think it's an entire school of thought that he trained.
I'm happy we're in the same school of thought.
I guess he's a good mentor.
Yeah, he's great. I'll see him in a couple of weeks. I'm going to be going to Brussels, and I'll tell him that I spoke to you.
Well, say hello, and yeah, miss him.
Super. It's the perfect way of ending our conversation. And I would just ask our listeners to subscribe our channels on Spotify, on YouTube, and to follow us on Twitter and all the social media we are on, because it's important for us to have followers and have subscribers to continue produce good contents for all of us. So thank you once again to Sean and Ana, and see you in the next episode of the Journal of Clinical Monitoring and Computing interview series.